Hello, everyone. Thank you very much for joining this morning or this afternoon, wherever you are. Welcome to today's webinar. We will give just another minute or so for some more people to join, and then we'll go ahead and get started with the presentation. All right, so we will go ahead and get started this morning, and more folks will join as the minutes go by. So good morning and hello, everyone, and welcome to today's webinar, which is hosted by Hepatitis Delta Connect. My name is Beatrice Sovich, and I'm a public health program manager at the Hepatitis B Foundation and the manager of our Hepatitis Delta Connect program. Thank you all for tuning in today. Today's webinar is focused on research that was recently published in the Journal of Hepatology, which includes important data about health-related quality of life and patient-reported outcomes for individuals living with hepatitis delta. We will have an opportunity today to hear from Dr. Maria Buti, who will share an overview of her work in this area as it relates to a trial being conducted on people currently being treated with bulevirtide, which is the recently and presently only approved medication for hepatitis delta. So we're looking forward to a great presentation. Next slide, please. So before we get started, I would like to remind all participants that during today's webinar, all audience members are muted. We encourage you to use the chat feature to let us know who you are and where you're joining from. And if you have any technical challenges, please indicate your issue using the chat box and we will address it as soon as possible. At any time during the presentation, you can enter questions into the Q&A box, and questions will be addressed by Dr. Buti at the conclusion of the presentation. The session is also being recorded, and presentations will be shared following the webinar. Next slide, please. Thank you. So just a quick overview of our program. Our Hepatitis Delta Connect is a dedicated program of the Hepatitis B Foundation, and it was established in 2016 for the explicit purpose of raising awareness about hepatitis delta and promoting diagnosis, screening, research, and linkage to care, as well as providing support to those living with and affected by hepatitis delta through a variety of channels, including email and phone consults, social media, newsletters, blog posts, a website, and focused advocacy and webinars such as this one. We also run hepatitis delta focused events, and we lead Hep Delta public health research projects. We're hoping to continue to build and expand our programming throughout 2024 and in the years to come, and we'll keep you posted about these efforts and further opportunities to get involved. Next slide, please. So today we are very excited and honored to be joined by Dr. Maria Buti, who is a professor of medicine and consultant of hepatology at the University Hospital Vall in Barcelona, Spain. Dr. Buti is a leading global expert in liver disease who has worked in viral hepatitis for the past 35 years, particularly in diagnosis and therapy of hepatitis B, C, and D. Dr. Buti was president of the Spanish Association for the Study of Liver Diseases and is an active member of both the European and American Associations for the Study of Liver Disease. And she's published over 500 papers in the fields of liver disease and has contributed to numerous books as well. So we're very excited to hear from Dr. Buti today, and we're grateful to her for joining us. We invite audience members again to put any questions you may have in the Q&A box as they arise, and they will be addressed at the conclusion of the presentation. And a note that this webinar will be 45 minutes rather than an hour in length. So without further ado, we invite Dr. Buti to begin her presentation. Thank you so much.
Thank you very much for your introduction, and many thanks to Hepatitis B Foundation for inviting me to be part of this webinar. Let's start sharing the slides. Okay, can you see the slides?
Yes, we can.
Okay, so good morning, good evening, good night to everybody. I am going to focus today on hepatitis delta and patient-reported outcomes. As you know, hepatitis delta is the most severe form of viral hepatitis, and the risk of disease progression to cirrhosis and hepatocellular carcinoma is higher than other viral hepatitis. For this reason, hepatitis delta is extremely important for patients, and we know that hepatitis delta is the smallest virus. It's a single-strand RNA genome, which is associated with viral proteins, and always hepatitis delta needs an envelope that is provided by hepatitis B surface antigen. So there is no hepatitis delta infection without hepatitis B infection, and I think this is a critical point to understand better hepatitis delta infection. The global prevalence of hepatitis delta is not very well understood. There is several studies in some countries, not in all countries, and there is a high prevalence of hepatitis delta, particularly in sub-Saharan African countries, in the majority of European countries, and also in US and South America. Hepatitis delta is not very often present, and it has been estimated between 12 and 60 million of people are infected with hepatitis delta. The issue on hepatitis delta is that the access to a screening and diagnostic test is limited, particularly in countries, in low-income countries. That makes very difficult to establish the real prevalence of this infection. But what is clear, and as I mentioned at the beginning, that the progression of the disease and the rate of decompensation and negative outcomes such as liver cirrhosis, HCC, a liver transplant, hepatic decompensation, and mortality is much higher, between 2 and 6 times higher in patients co-infected with hepatitis B and delta than in those mono-infected with hepatitis B. We have interest on patient-reported outcomes for a long time. We have collaborated in patient-reported outcomes in patients with hepatitis C and also in hepatitis B. And in viral hepatitis, patient-reported outcomes has been mainly evaluated in patients with chronic hepatitis C, and we know that with direct antivirals, and particularly with hepatitis C cure, there is an improvement in patient-reported outcomes. We did some years ago the first study on patient-reported outcomes in untreated patients with chronic hepatitis delta, and this has been published in GEP reports 3 years ago. In this study, we analyzed the health-related quality of life determined by patient-reported outcomes in untreated patients with chronic hepatitis delta, and we compare the results with patients with chronic hepatitis B. At the end, we collected 43 participants that completed 3 different patient-reported outcome questionnaires, one on chronic liver disease, that is CLDQ, another on fatigue, the FACIT-F, and another on work productivity and activity impairment. And the results of this were compared with 82 patients mono-infected with chronic hepatitis B. These are the main results of this study. Untreated patients, please remain. Untreated patients with chronic hepatitis delta, and you can see that untreated patients have a worsening functional assessment of chronic illness on chronic liver disease questionnaires, but work productivity activity is not impaired. It's more impaired in patients with B than in patients with hepatitis delta. So in summary, and this is the graphical abstract of this paper, in this cohort of patients with B and Delta, using these questionnaires of patient-reported outcomes, we find that patients with Delta have worse score, particularly worry, abdominal symptoms, also in fatigue, physical well-being and emotional well-being, but there is work productivity and activity remains preserved. After this, we have work in patient-reported outcomes in patients treated with bulevirtide. As you know, there are two treatments available for hepatitis delta, at least in Europe, PEG interferon and bulevirtide. And what we have done with this entry inhibitor, bulevirtide, it's an entry inhibitor for hepatitis B and delta. It blocks the receptor, the NTCP receptor, which is the receptor that use hepatitis B and of course also hepatitis delta to entry to the cells. It's a drug approved and very often used in Europe for patients with hepatitis delta. And it's administered with a daily subcutaneous injection. The safety profile is excellent. There is only an increase in bile acids, but this increase doesn't translate in any clinical manifestations. This drug has been evaluated in a large study, in a registration study for this drug, a phase III study in which 115 patients with hepatitis delta were randomized to receive no treatment for 1 year after the 10 milligrams of bulevirtide subcutaneous every day, or bulevirtide 2 milligrams subcutaneous every day. This is the dose approved for Europe, or the highest dose, 10 milligrams subcutaneous every day for 3 years. And in this study, quality of life has been analyzed in different time points: at baseline, at week 24, at week 48, after 1 year, after 2 years, and now after 3 years of treatment. Patients were randomized 1:1:1. It's an open label study and were stratified by the presence or absence of liver cirrhosis. I am going to focus with the approved dose in Europe, that is 2 milligrams versus control during the first year of treatment. And you can see that the baseline characteristics, the demographics are very similar. Half of the patients in this study had liver cirrhosis. That is very usual in patients with hepatitis delta, and there is no difference between both groups. Here are some data on efficacy that I think it's important. During these 2 years of treatment, the combined response defined by undetectable HDV-RNA or more than 2 log decline in HDV-RNA from baseline and ALT normalization with the 2 milligrams was observed in 45% of the cases during the first year and 55% during the second year. This it was translated in an overall virological response of 74% and 76% in the first and second years, and with a lower proportion of patients with ALT normalization. And you can see that this contrasts with the delayed treatment with the control group, that during at the end of the first year, only 2% achieved combined response, 4% virological response, and ALT normalization 12%. I would like to highlight the viral response and ALT normalization increase with longer after bulevirtide treatment. This virological response and biochemical response is also associated with improvement in liver stiffness, persistent improvement in liver stiffness, and there is no HBs antigen loss during the study as it is expected because it's an entry inhibitor, the drug. Now, let's go to the patient-reported outcome. Here, the questionnaires used are a bit different than those used in my study. Here, the health quality of life was analyzed by the 36-item short form health survey questionnaire. And in this questionnaire, there is also an additional questions specifically for hepatitis. So a total of 15 supplementary questions are in this survey. And we analyze the changes at these different time points, and higher scores indicated better quality of life. So here you have the results at week 48 in the 49 people treated with bulevirtide. And you can see and in the control group, in blue, those treated with the drug. And we can see an improvement in the majority of the domains: physical domain, role physical, bodily pain, general health, vitality, and so on. And for me, what is also most important, it's an improvement in disease-specific questions, in health distress, positive well-being, and health limitations and health distress. So this is during the first year. And then we look what happened in the follow-up at week 48 and week 96. And again, you can see here improvement in the majority of the components of the patient-related outcome. And this improvement is maintained and even increased during the follow-up after the second year. And when we compare all of this improvement from baseline with the baseline, you can see that in all the domains, there is a substantial improvement that is defined more than 15 points from the baseline in the different domains, and specifically in health domains and health distress. Health distress is one with the largest improvement, and this is observed only in patients receiving bulevirtide 2 milligrams. So this study has some limitations, and I think it's important to report the limitations. And the limitations, the first limitation is that the study, it's an open label trial design. This sample size is relatively small. There is 49 patients in the treated group and 49 in the control group. The study is mainly performed in Europe. There is no patients from other continents like Africa, and very few Asian patients. So these are probably the main limitations, and these limitations may reduce the sensitivity of the questionnaires to detect difference in patient-reported outcome between the treatment and control groups, and prevent broad generalization of these outcomes to all populations group. And it's important in health quality of life studies have different populations from different countries, because the results can be generalized. Additionally, there is an inherent detraction of PRO's questionnaires in the subjective nature of patient response, which may differ, as I mentioned, across race, ethnicity, and also geography and country. And finally, due to ethical considerations, the control group was only for the first year. So beyond 48 weeks, there is no control group because all patients were receiving treatment. And this is a limitation because it's only analyzed in a short term. So in conclusion, I think patients treated with bulevirtide 2 milligrams reported numerically greater improvements from baseline to week 24 and beyond in all domains. More domains improvements, including general health, bodily pain, vitality, social functioning, and role emotional, were observed with bulevirtide 2 milligrams than the delayed treatment, the control group. But further research is needed to understand better the burden of illness, the course of the disease, and the long-term effects of treatment on patients' health-related quality of life. And now this study treatment finished after 3 years, and there will be follow-up under treatment with, again, evaluation of PROs. And I think this will be really also important to see what happened with PROs when treatment is stopped and if it's maintained, not only the virological response, also the improvement in the quality of life. So I think this is all, and we can open the discussion if you like.
Thank you so much, Dr. Buti. This is a great presentation, and thank you so much for your work on incorporating these important aspects of health-related quality of life into studies of new medications. We had a couple questions come through. So one is from Rav in Canada, who mentioned that thank you so much for this presentation, as living with hepatitis B and Delta for almost 40 years and developed compensated cirrhosis, and recently went through 48 weeks of treatment with PEG interferon and achieved undetectable levels of hepatitis B and D. Based on these studies, is it reasonable to expect some improvement in liver stiffness, in your opinion?
Yeah. Thank you for the question. I think you have to expect improvement in liver stiffness. This has very well proven in patients with hepatitis B and with hepatitis C. When the virus becomes undetectable, there is improvement, particularly because one of the components of the FibroScan is inflammation, and there is a reduction in the inflammation. I expect that your score will decrease during the follow-up. And congratulations to achieve undetectable viremia, because this happened, but not in 100% of patients, like in hepatitis C. Elimination of Delta virus is less frequent. It's more difficult than in other viral hepatitis.
Perfect. Thank you so much. We have another question that came through. This is an excellent presentation. It is exciting to see PROs being used for hepatitis Delta treatment to assess quality of life impact. What do you think it will take to get quality of life assessment included in future medical society guidelines for the management of hepatitis B and Delta?
Thank you, Chari. Thank you for the question. I think it's really important to include in guidelines patient-reported outcomes. Not only patient-reported outcomes, I am in favor that patients living with diseases are also part of the guidelines. the opinion of the patients and what the patient feel is really important, not only for recommendations, also when new drugs are evaluated. And I think now in all clinical trials using new drugs under investigation, patient-reported outcomes is now compulsory.
That's great to hear, and very important that this will be moving forward and the standard in the future. I just want to note that a recording of the meeting will be sent out to all registrants. I think that was a question in the chat. We had another question or comment. Please consider target not detected. Always depends on the sensitivity of respective analysis. So I think that was just a comment. I don't know if you wanted to comment on that.
Yeah, with hepatitis delta, the sensitivity of the test to evaluate, to assess viremia, it's sometimes tricky. It's tricky because the test, there are very few commercialized tests. Some of them are not very well standardized. And I think the access to this test they are not available to everybody. So the best is target not detected clearly. But in the majority of these studies, in the registration studies, it's used the two-log decline more than target not detected. Why two-log decline and not target to detected? Because there is an initial study performed some years ago suggesting that two-log declines could be useful and could help to less clinical events. But clearly having more drugs under investigation and better drugs, probably, not probably, but sure, we have to go to undetectable viremia. But this is the beginning in hepatitis delta, and I think now we are going to have better tests and also more drugs, or at least probably combination of different drugs.
Perfect. I actually had a question just based on the charts where you were showing the quality of life indicators that you included in the assessments. And I was just wondering if you could speak a little more about the questions that were asked. I know that there were measurements of things like physical component, but also the role of physical health and vitality, and then a mental component and emotional role of emotional health. So if you would be able to just elaborate a little more on some of the questions that were asked and how people responded.
Yeah, there are very easy and simple questions about how do you feel today, if you sleep well, if you have capacity to interact with other people. And what I think is very good of this questionnaire, the short report for 36, there are 36 questions that are general for different diseases. The questionnaire is very, very well validated. It has been translated to different languages. That it's an advantage because you can use this in different populations and then you can compare the results. And this SF36 has been used, as I mentioned, for different diseases, but then there is 11 additional questions related to liver disease that I think are complementary and are, it's easy. You can Google short for 36, you can see the questions, but are very easy questions and are related with your daily activity.
Perfect. Thank you so much. And that's good to know that, it can be transferable to other groups as well, to explore other factors like race and ethnicity, as you mentioned, and other areas as well. Was there any, and then I'm also just curious if, so people generally stay, or how long are people currently staying on bulevirtide? And just, as I know 96 weeks was a follow-up was conducted. Are people good to stop the medication, or it's just, or not enough research has been done yet?
Yeah, thank you. Thank you for the question. Up to now, the longest treatment with bulevirtide, it's 3-4 years.
Okay.
And the majority of patients continues with treatment because the criteria to stop treatment could be because it's not very well proven, undetectable viremia, persistent undetectable viremia. Some patients in a preliminary phase 2 study stop treatment after 1 year of treatment, and the majority after stopping treatment relapse. So that means that there is 1 year, it's not enough. Now the study, this phase 3 study that I have presented, has reached 3 years, and patients are now stopping. So it will be very important what happens after 3 years in those with undetectable viremia, if they maintain off therapy undetectable viremia, or there are relapse. So I think probably next year at EASL, we will see the results after stopping treatment. And another thing that it's important is that there is a study combining PEG interferon and bulevirtide. And this study has a completely different approach. And the approach of this study is finite treatment duration, 1 year, and what happened. And we know, and this has been recently presented, that some patients, approximately 30% of patients, achieve persistent undetectable viremia. Persistent means 48 weeks of therapy. So clearly we need more investigation. In my understanding, I have never seen patient-reported outcomes in patients under combination therapy, but using interferon, I am sure that patient-reported outcomes during treatment will be worse than with monotherapy with bulevirtide alone. So clearly we need more research in hepatitis delta and more awareness. So I think having this type of webinars that are promoting awareness and also increase screening and diagnosis are really important.
Yes, absolutely. There's still so much. The story is still very much unfolding. And there's a long way to go in terms of still continuing to test people for hepatitis delta and get accurate epidemiology as well. I just had one other question, and I was just wondering if anything about financial strain was assessed as part of the patient-reported outcomes. I know many people who have access to bulevirtide are in Europe, where socialized medicine is more prominent, but were there any financial concerns with taking the medication that were expressed at all?
Yeah. As you mentioned, in Europe, in the majority of countries with our public health system, drugs are provided free for patients, but we have some limitations depending on the country. Okay. In the majority of countries, it can be given without any problem in patients with liver cirrhosis. But in patients with less disease, less liver disease like chronic hepatitis or low fibroscans is not reimbursed for the healthcare system. And and I think this is the limitation, that in some countries they ask for some degree of liver damage, that means the presence of liver cirrhosis, to have free access to the medication.
Okay. Yeah, I know that that can be a big concern in, in other places, such as, when the medication hopefully gets approved in the United States, cost barriers will likely be an issue. So, so that's good. That's good to know. So I think that I don't think there's any other questions, but we so appreciate your time and this great presentation and very, very important work. So thank you so very much. I think, Shreya, do you mind just sharing the last slide of the presentation? And I'm just quickly going to put 2 links in the chat to some of our Hepatitis Delta newsletters that we have. So we encourage everyone to sign up for these. But just a big thank you to everyone for joining today's webinar and to Dr. Buti, our wonderful speaker. We hope that you found this to be informative and valuable to your work and life, and that you can apply some of this information moving forward or have learned something new. We encourage you to complete the evaluation form when the webinar concludes. And again, a recording of the webinar will be emailed out to all registrants. Again, we encourage you to sign up for our newsletters for both providers and people living with hepatitis delta, to be added to our mailing list, where you can receive regular updates about hepatitis delta drug development, clinical trials, research, news, and events like this one. You can find those links in the chat, and those will also be emailed out after the presentation as well. And please do feel free to reach out and get in touch with us using the contact information on the slide, and to visit our website for more information. And we thank you so very much again for joining, and thank you, Dr. Buti, for being with us. We really, really appreciate it.
Thank you again for the invitation. It has been a pleasure.
Wonderful. Thank you so much. Have a great rest of the day, everybody.